went to medical school at MCW in Milwaukee. Then I did my residency at WashU in St. Louis. And then I did my cardiology fellowship at the University of Oklahoma, in Oklahoma City. And then I did my interventional year at UW-Madison. But I found my way back to Wisconsin, which is I think the most important. What do you think?
I think keep rolling.
Okay.
Yeah.
Well, again, my name is Dr. Varghese. Like I said, I'm one of the interventional cardiologists, and we're going to be talking about minimally invasive treatment of valve disorders today. So, thank you for being here. Get this to work. Had all this time to get it to work. It's also got all the perfect. Okay, we did all the way until we were done. Okay, so what we're trying to talk about today is to just give you guys just a like a brief overview of kind of the variety of heart valve disease that's out there. Briefly talk about some of the treatment options that we have for those valve problems. You guys are going to sense a very common theme very quickly, right? In that we have certain ways to treat some of these valve disorders. We don't have a lot of kind of minimally invasive ways to treat the majority of them, but we will talk about minimally invasive treatment options that we do have. And then we'll kind of finish up with talking about something that we do here, and that's a minimally invasive way of treating a valve disease called aortic stenosis. And you treat it with this procedure called TAVR, right, which is transcatheter aortic valve replacement, and we'll get into that in some detail as well. If anyone has any questions along the way, feel free to stop me and we can chat about whatever. So, some of the more common valve disorders that we see and that you guys may have heard of are aortic regurgitation, mitral valve stenosis, mitral valve regurgitation, tricuspid regurgitation, and aortic stenosis. So we'll kind of talk about each of these one by one here. So aortic valve regurgitation, I don't know if you guys can see this all the way in the back, but this is the aortic valve, right? And the aortic valve separates the left bottom chamber of the heart, which is called the left ventricle, from the aorta, which is the big artery that comes off of the heart. And so typically, the aortic valve is supposed to prevent any blood from leaking backwards, right? But in certain conditions, there can be some leakage of the blood backwards into this left bottom chamber of the heart. And so there's several conditions that can cause it. If you had, kind of enlargement or like an aneurysm of this part of the aorta, that could cause the valve to stretch, and then you could have some leaking of the valve that way. There are some kind of more emergent things that can cause it. If you were to have damage of the aorta, kind of emergently, they call it a dissection, that can cause it. If you had an infection of the valve itself, that's called epicarditis, that could cause it. If you were born with kind of congenitally malformed valve with 2 leaflets instead of the usual 3, sometimes those folks can have leakiness of the valve. And then sometimes stenosis or narrowing of the valve, which is another problem we're going to talk about, sometimes that can cause both stenosis, which is tightening, but it can also cause leakiness because the leaflets themselves kind of become thickened and calcified, and they don't close kind of very cleanly. They don't form a very good seal, and so that also can sometimes cause the valve to be leaky. So this is a very nice picture that I stole from one of my colleagues, very shamelessly. But this is the aortic valve, right? So this is what's called an echocardiogram, right? An echocardiogram is a sound picture of the heart. This specifically is a special kind of echocardiogram. It's called a transesophageal echocardiogram. It's a probe that you swallow. And so it gives us these very, very close-up, very clear views of the heart valves and leakiness of the heart valves. And so just to kind of orient you, this is the left top chamber of the heart. It's called the left atrium. This is that left lower chamber of the heart. It's called the left ventricle. Those two things are separated by the mitral valve here. We'll kind of talk more about that, in a little bit. And this is the aortic valve, right? So this aortic valve, like we showed you in that other picture, separates the left lower chamber of the heart from the aorta, which is the big artery that comes off the heart, right? And so in this case, all this flow here, this blue jet that you see kind of going from here backwards shouldn't be there, right? So all that blood should be going in one direction. All that blood should be going from the left lower chamber of the heart out through the aortic valve and then out through the aorta. But in this case, you see that there's all this blue jet here is all that blood leaking backwards, is basically what that is. And so when we evaluate folks for aortic regurgitation, sometimes this is one of the tests that we'll get to kind of get an idea of how much regurgitation is there. This is a very clear way of kind of seeing what that looks like by hand. So one of the very, very, very common themes you guys are going to see is that a lot of the valvular heart disease that we deal with tends to have fairly similar symptoms, right? And almost universally, a lot of the valve problems that we see, people come in complaining of shortness of breath, probably more so than anything else, right? And so you'll see this kind of as a recurrent theme for valvular heart disease, that a lot of people come in and more often than not, at least one of their presenting symptoms tends to be shortness of breath, and that kind of holds true for aortic regurgitation as well. Treatment options for aortic regurgitation, if that leakiness of the valve is severe and people have symptoms related to it that we think are related to the valve, aortic valve surgery tends to be the most common treatment option, right? And so that's open heart surgery. They have to replace the aortic valve. There are some medications that we can try to help with some of those symptoms, but those medications aren't a substitute for actually replacing the valve, right? So those medications kind of help with the symptoms, maybe kind of make things a little bit better, but it doesn't solve the underlying problem, which, like we said, typically would require some kind of surgery for the aortic valve itself.
Do you use animal valves for aortics?
For aortic regurgitation? Yes. So they have surgical, the question was, do they use animal valves for fixing this problem? And the answer is yes, right? So they have two flavors of valves, right? So they have mechanical valves, which are fully metal, and they have what they call bioprosthetic valves, right? So bioprosthetic valves are part metal and part some kind of animal tissue, right? And so typically that animal tissue either comes from cows or pigs. Okay? And so you guys probably talk to some people that you know that either have a cow valve or they have a pig valve. But typically those are the two most common flavors of animal tissue that's used.
Do both require anticoagulation?
No. So it's a good question. The question was, do they both require anticoagulation or being on blood thinners? And it's typically only mechanical valves that require being on blood thinners. If you had a bioprosthetic valve, with animal tissue in it, then typically those people don't need to be on blood thinners. The trade-off is that mechanical valves that are all metal, they tend to be more durable, right? So if we had somebody really young that needed a valve replacement, a lot of times they'll get a mechanical valve because you need that valve to last them a long, long time. The downside, obviously, is that you need to be on blood thinners. Conversely, if you had somebody that maybe wasn't that young and maybe wasn't such a great candidate to be on blood thinners, then maybe a bioprosthetic valve might be a better option for that person. Good question. So, kind of moving on, mitral stenosis. So we kind of talked about that valve called the mitral valve, right? So that's the one that separates the top left chamber of the heart from the bottom left chamber of the heart. And so in some people, you can have this thickening and narrowing of the opening of the mitral valve, right? So typically the mitral valve is supposed to be, kind of pliable and opens, very widely and easily. But in certain conditions, we see that there can be thickening and narrowing of that orifice. And so if you think about it, this valve that's supposed to kind of open freely and allow the blood to flow from the top to the bottom chamber on the left side, if it's this tight, right, it causes this restriction to blood flow, which can lead to problems. So there's a couple of common causes for mitral stenosis. Rheumatic heart disease used to be a very, very common reason. There are certain parts of the world where rheumatic heart disease is still very common. India, for example, there's still a lot of rheumatic heart disease. And so that can be one cause for mitral stenosis. Mitral annular calcification, sometimes over time, that can be an age-related change where you have calcium around the border of the mitral valve, which can cause mitral stenosis. And then sometimes there are some drugs and things that can cause mitral stenosis as well. A lot of those were kind of in the past, we don't see a lot of those drugs anymore. So like we said before, a very, very common symptom of mitral stenosis tends to be shortness of breath. Some of these folks can have chest pain as well, but most often that's what they would present with. Treatment options for mitral stenosis, depending on what your mitral valve looks like, right? There are certain evaluations we do for how thick it is, how much calcium it has. Using a balloon to try and stretch open this valve can sometimes be an option. So you essentially put a balloon across this opening, and then you inflate that balloon to try and stretch open that valve, thereby trying to increase the size of that opening. You're allowing more blood to flow, and try to help with the symptoms that way. So that's one option, but that depends on a number of things. The valve has to kind of be suitable to undergo a valve balloon procedure. And then the other option is mitral valve surgery, right? So where they go in and they replace the valve, just like we talked about with either mechanical valve or diaphragmatic valve. Mitral valve regurgitation is this problem whereby instead of a narrowing problem, again, it's a leakage problem, just like the aortic regurgitation that we talked about. And so instead of keeping all the blood flowing one direction from the top chamber on the left side to the bottom chamber, blood can leak backwards into this top chamber of the heart. So there are different flavors of mitral regurgitation. Some people can have damage to some of these leaflets. Either they were born that way, or they can have damage to these structures that kind of hold those leaflets in place. And so the leaflets that did look like this before, if you have damage to some of those structures, all of a sudden you can have one of those leaflets kind of balloon or parachute up, right, which then causes a lot of blood to leak backwards in the direction that it's not supposed to. And then you can have some blood flow issues, right? So if you think about these structures, right, they're supplied by heart organs, right? So these muscles need blood supply. So there are certain instances where people can come in with a heart attack. And if you have a lack of blood supply to some of these muscles that are holding these structures in place, you can have something that's called ischemic mitral regurgitation, right? So as a result of this lack of blood supply, those muscles don't work as well, the leaflets aren't tethered properly anymore, and you can have leakiness of the valve that way. Certainly sometimes if you fix the blood supply problem, then that leakiness could get better. And another problem is if the structure that this valve is suspended in itself, right? So the valve spans from this side to this side across this chamber. But if you think about certain things that could cause that chamber to become larger, right? So if that chamber were to stretch, it would take those leaflets that were kind of nicely touching this way, and you could kind of pull them apart a little bit, and you could think about how that would cause the valve to be leaky as well, right? So those are two forms of what we call functional mitral regurgitation for different reasons. So this is an example. It's a very similar view to the other view that we saw in echocardiogram by transesophageal echo, where you have the mitral valve, but clearly you can see there's something moving here that's not supposed to be moving, right? And so this structure there is a part of the leaflet that's become untethered. And so then that leaflet, instead of kind of staying where it's supposed to be, kind of flails or prolapses up, right? And so when it does that, it allows blood to leak backwards back into that top left chamber of the heart. This is a still frame view of what that leakiness looks like, right? So where all the blood is supposed to flow this way, this colorful jet you see coming up and around is blood leaking back from the bottom chamber of the heart on the left side through the mitral valve and up into that top left chamber. So once again, right, very, very commonly, we see folks with mitral regurgitation complaining of shortness of breath. Sometimes they can also complain of fatigue. Treatment for mitral valve problems depends a lot really on what's causing it, right? So if we went back a couple of slides here. So this kind of a problem where you've got something that's become untethered and it's caused a part of the leaflet to come loose. that tends to be a problem that surgeons can repair, right? So rather than replacing the entire valve, rather than cutting out the whole valve and just putting in a new mechanical or bioprosthetic valve, surgeons can go in and just kind of cinch up the area that's kind of become loose or untethered, and they can fix it that way without having to cut out the whole valve, right? And so a lot of times, if it's possible to repair a mitral valve, more often than not, that's more desirable than replacing the entire valve. Okay. Certainly, there are some cases where it's not possible to repair the valve, and so you may have to replace it entirely. And there are some more minimally invasive options. We talked about how not all valve problems have kind of minimal options to treat them, but certainly mitral regurgitation is one that we do. So there's a device that's called MitraClip. And so basically what it does is, if you've got this, this valve that's just kind of leaking severely, what it can do is it takes a clip and attaches it to the front and back leaflets, and you kind of pitch them together. And the idea is that by doing that, you reduce overall how much leakiness there is, right? And so what you see here is that the device, right, has these two kind of arms to it, and it gets passed from the left top chamber to the left bottom chamber, and then as it's drawn back, you use those two arms to kind of grab the ends of the leaflets, right? And then as it grabs those leaflets, it kind of cinches them together, and then it ends up looking a little bit like this, right? And so you've essentially created a little bit of a narrowing, but by cinching those two leaflets together, you're trying to reduce overall how much blood is leaking back into that top chamber. And so the MitraClip procedure has been done in this country for several years now. We just had a meeting today about considering whether or not we want to start doing that procedure. So certainly there are some options for mitral regurgitation that doesn't involve open heart surgery. So kind of moving on now to the tricuspid valve regurgitation. The tricuspid valve is a valve on the right side of the heart. It separates the top right chamber from the bottom right chamber. And there's a couple of reasons that the tricuspid valve can become leaky. Sometimes, like we said, if that chamber, if the chamber that the valve is suspended in itself, right, becomes enlarged, that can pull apart the leaflets, just like it can for mitral regurgitation. If you have very high pressures in the lungs themselves, sometimes that pressure in the lungs can be reflected into the tricuspid valve, and that can cause the tricuspid valve to become leaky. There are some other causes for tricuspid regurgitation, like prolapse, which was similar to that ballooning that we talked about that can happen with the mitral valve. If you were to have a pacemaker lead or a defibrillator lead or something going through that tricuspid valve, you can imagine how a lead like that could sometimes pull apart some of those leaflets, and that could cause the valve to be leaky. There are some other diseases such as carcinoma, which is what this demonstrates, that causes kind of thickening of the valve leaflets itself to where they don't open freely anymore, but then they also kind of don't close completely, and that can cause them to become leaky.
What do you do for a device
if a lead's causing it? Sometimes they can be adjusted. A lot of times, if it's not causing the person too much trouble, we tend to leave it alone. We have Dr. Mariano here.
Yes, almost all wires will cause some degree of leak, but usually it's very minimal because the tricuspid valve of all the valves, it's quite big. The leaflets are quite large, and so when the leaflets close against that pacemaker wire, they tend to wrap itself around. So the leak is usually not very severe, and it's very rare that the wire, the pacemaker wire or the defibrillator wire coming across the valve will cause a leak bad enough to require any type of treatment. If it is causing enough leakage, though, that it's causing significant symptoms, you often have to go in there and remove the wire and reposition it in such a way that it doesn't impinge on the valve function. But that's very uncommon.
So if everyone caught that, most of the time the leaflets are kind of billowy enough that kind of accounts for that thing that goes past it. But otherwise, if it was causing a significant problem, then sometimes it does need to get removed and then readjusted to a position that hopefully isn't causing that problem. So if you think about tricuspid regurgitation, it's basically leakiness that's going from the right bottom chamber to the right top chamber, right? And then that right top chamber is then what's connected to the rest of your veins. So all the veins from your legs and your abdomen and everywhere else drains into that top right chamber of the heart. So if you have something that's causing a lot of leakiness into that top right chamber of the heart, you can see some of that extra fluid and pressure be reflected back down into the veins of your legs and into other areas that are kind of upstream from that. And so some of the symptoms that we see related to tricuspid regurgitation is a direct cause of that, right? So you can see a lot of leg swelling, you can see swelling in the abdomen, and then depending on severity, you can see other related symptoms like fatigue, weakness, and then yes, of course, shortness of breath as well. But by and large, symptoms of lower extremity swelling, things that we call right heart failure symptoms, tend to be kind of the hallmark of tricuspid regurgitation. The treatment for tricuspid regurgitation involves medications that can help deal with that extra fluid, kind of help with some of that swelling, and then certainly tricuspid valve replacement or repair can also be done. More often than not, we see tricuspid valve repairs, where they're able to go in kind of with a ring and kind of cinch up that opening to where it doesn't leak anymore. And then sometimes the treatment just depends on what's causing it. For example, it was related to a pacemaker lead or something like that. So moving on to aortic stenosis. So aortic stenosis is a very, very common problem. We see it pretty routinely. There's a couple of different causes for aortic stenosis. Some people are born with kind of a misshapen aortic valve, right? So an aortic valve typically has 3 leaflets, right? So three valve leaflets. But some people are born with just 2 leaflets. And so an aortic valve that only has 2 leaflets isn't quite as well suited to kind of deal with like the rigors of doing its job. And so they tend to break down early, right? And so if we see somebody who has regular aortic stenosis, right? So this is what's called tri-leaflet, right? There's 3 leaflets to the valve. Tri-leaflet senile calcific aortic stenosis, right? So typically we see people with that problem in their 70s, their 80s, their 90s. You might see somebody with bicuspid valve aortic stenosis quite a bit sooner, right? So you might see them in their 50s or their 60s because that valve breaks down sooner than a regular leaflet with 3 leaflets. Rheumatic fever, we talked about a little bit with mitral stenosis, but it causes a similar problem with kind of thickening of the valve where it doesn't open as freely anymore. Again, fortunately, a problem that we don't see that often. And then we already talked about kind of the most common flavor of aortic stenosis, which is what we see most commonly, which is as people get older, they have kind of calcium deposits on the leaflet. The leaflets themselves become kind of thick and non-pliable. They don't open as well, they're stiff, and they lead to this opening problem with the valve. It's called aortic stenosis. In some people, you can have just kind of thickening of the valve, but it still opens well, right? In those people, you can hear a murmur, and they're described as having what's called sclerosis without actual stenosis or narrowing of the valve itself. We talked about these 2 flavors of aortic stenosis, the senile calcific trileaflet aortic stenosis and then the bicuspid valves. Then certain risk factors for aortic valve stenosis, certainly age, right? Because we see it in the elderly, smoking, high blood pressure, hyperlipidemia or high cholesterol. Then there is a kind of predisposition to having this problem in men more so than women. So some more images. This is another transesophageal echo image. So if you look at this valve, right, you can see along the edges here, right, it's very bright, right? So all the dark black spots are blood, and these spots along the edges of the valve leaflet are very bright, right? So calcium shows up very bright on echo, which is what this is, right? So the edges of these leaflets, rather than being kind of thin and crisp and pliable, are very thick, right? They've become thickened and calcified, and they just don't open very well, and that's what we see on echo. So where this orifice here should be kind of wide open, right? So every time the heart beats, that orifice should be wide open, allowing blood to flow. But instead, you see the leaflets themselves, barely move, right? They just budge a little bit. You have a question?
Yes. I think I've been told that radiation can hurt your heart. I have trouble with regurgitation. Is that common?
It's not common, but we certainly see it, right? And so chest radiation, for example, right, can cause many things, right? It can cause certainly accelerated valve degeneration. So sometimes we do see things like aortic stenosis from damage from radiation. Certainly that's one somewhat uncommon cause for it. We see it more commonly just because we see a lot of patients with valve disease, but certainly that can be something that causes it.
Yeah. How often do you see, or do you ever see, sudden death as a result of severe aortic stenosis?
So it's sudden death can be one of the presenting symptoms of severe aortic stenosis. So fortunately it happens rarely, but it certainly can happen. This is just another view of the same valve, where again you see these leaflets that are supposed to be kind of opening widely. You see are kind of thickened, and they just don't very well. This is another image, kind of in 3D of the same valve, where you see kind of these very, very thickened leaflets that just don't open very well. Certainly aortic stenosis isn't a problem that's going away anytime soon. As the population ages, it becomes a more prevalent problem, certainly, and it's something that we're going to be seeing quite a lot of in the years to come. So again, kind of like we talked about, the most common symptoms of aortic stenosis tends to be shortness of breath, angina or chest pain, fatigue, or syncope, right, or passing out. And sometimes when people pass out from aortic stenosis, sometimes they don't wake up, right? So to answer your question, right, sometimes the way that people get diagnosed with aortic stenosis is that they just lose consciousness, and sometimes they don't wake up. Fortunately, that happens rarely, but certainly it's possible. Other times people can present with palpitations or kind of heart fluttering or heart racing, and it can also predispose you to some heart arrhythmias, right, which can give you some of those symptoms. What's interesting is a lot of times the folks that have this problem, right, so we said that they're usually in their 70s, 80s, and 90s, right, and a lot of times these folks come in and they think that perhaps they feel this way just because they're in their 70s, 80s, and 90s. Aortic stenosis tends to be a problem that develops slowly, right, over years, right, to go from mild to moderate and then eventually severe. And so a lot of folks think that it's just kind of par for the course for them, right? They're just at an age that they should feel this way, and so they assume that's why they feel that way. But in a lot of cases, the reason for their symptoms is a valve problem, right? And people gradually just kind of acclimate to the symptoms that they have, right? And so people don't want to be short of breath all the time, so they just do a little bit less. And then over a couple of years, they are doing significantly less than they used to years ago, but they just assume that to be kind of a common byproduct of aging. Whereas in fact, it's kind of a slow progression of this valvular heart problem, which causes them to feel that. So a lot of people ask when we see them in clinic, right? And we tell them that you've got severe aortic stenosis and now we need to do something about it. And a lot of times they're like, well, no. What if I just don't want to do anything about this problem, right? And so this graph is a great reason why we should do something about it. Because the prognosis, once you've been diagnosed with severe symptomatic aortic stenosis, is very, very dismal. it's very, very bad, right? So you see that once you get to this point, right, where you've got severe aortic stenosis and you have symptoms, you see that this is a survival curve, right? So this is how many people are alive. So as soon as you get to this point, it's like you fall off a cliff. So that's how dramatically your prognosis worsens once you get to that point. So not doing anything really is not a great option once you've been diagnosed with this problem. And so 50% of patients that get to this point die within 1 year, which is fairly dramatic when you think about it, right? So half of all people who get to that point aren't with us in 1 year. And that's not even taking account, past that. So just to kind of put things into perspective, right? So as far as metastatic cancers go, right? So this is breast cancer, lung cancer, colorectal cancer, prostate cancer, ovarian cancer, and this is severe aortic stenosis, right? So this is a really, really bad problem not to do something about. So when we look at, the kind of patients that present with severe aortic stenosis, and we're considering for, minimally invasive treatment options, these are a lot of the very common kind of characteristics that they all have, right? So they tend to be elderly, they tend to be kind of frail, and they tend to have this accumulated list of medical problems, right? Because they tend to be older. And so folks in their 80s and their 90s tend to have a lot of these medical problems, right? So they can have a history of strokes, they can have prior chest radiation, like someone mentioned, history of coronary artery disease, history of COPD, atrial fibrillation, kidney disease, diabetes, hypertension. And so the patients that we're seeing with severe aortic stenosis tend to be older, but they also tend to be sicker, right? They tend to have more medical problems just by virtue of the fact that they're older. Something that's very kind of important to try and figure out, right, is what kind of functional capacity folks have before you talk about doing something to them, right? Be that open heart surgery or even kind of a minimally invasive way of fixing aortic stenosis. And so we have several ways of trying to figure out kind of how robust are you, or conversely, how frail are you? So there's measurements like 15-foot walk test, grip strength, some lab tests like albumin, and then certain questionnaires like the CAS activities of daily living to try and figure out how frail or not are you. And in some instances, people are sometimes just too frail to either go through a procedure or to recover following the procedure. And so a lot of times, how well somebody does with something depends a lot on how well they are going into said procedure. And so sometimes these assessments help us understand the folks that may just not get better no matter what you do, because perhaps they're just too weak to either survive the procedure or recover sufficiently after. So as far as options, right, for treating aortic stenosis, unfortunately this is one where we have both an invasive option, which is kind of the tried and true open heart surgery, right, that everybody's heard of. That's where they open your breastbone and they surgically replace the aortic valve. And then the more minimally invasive option, which is TAVR, which is what we talked about at the beginning, which is transcatheter aortic valve replacement. And so when TAVR first started, right, it was only meant for very, very high-risk patients and high-risk patients. Since then, over the intervening years, that indication has expanded, right? And so now we're able to do this procedure on a broader kind of range of patients. So now it's officially indicated for moderate risk patients. The data has come out for low risk patients as well, and that also looks very promising, right? And so we're kind of waiting for that indication to be approved as well, and everyone's kind of fairly sure that it will be. But what that means is that moving forward, this minimally invasive way of trying to fix aortic stenosis is going to apply to the vast majority of patients, right? Whereas previously it was kind of reserved for, the very elderly, the very frail, the very sick, and fairly soon it's going to be available to the majority of patients that present with this problem, and then we'll have some kind of decisions to make as to what the best way is to treat.
Is there any difference between the outcomes with bicuspid versus tricuspid valve?
So all the trials that looked at the use of the minimally invasive technology excluded patients with bicuspid valves for the most part, right? Now that being said, there has been a lot of analysis looking at bicuspid valve patients since then. And a lot of that data looks promising, right? And so now there's debate as to which technology in particular, right? Because there are several companies that make TAVR valves, right? And so there's some debate as to, is one technology, is one method better to treat bicuspid valves over another? But I think more and more we're seeing, the majority of places treating bicuspid valve patients with the minimally invasive technologies. Part of the problem in trying to treat those patients is that we talked about the patients with bicuspid valve aortic stenosis tend to be younger, right? Like we said before, right? Because it's got 2 leaflets instead of 3. So part of the issue with that is those leaflets tend to have less calcium on them, right? They tend to be not as thick. And part of the problem, at least with some of the technologies used for TAVR, is that the valve depends on that calcification and that thickening to anchor itself where you put it, right? And so if you've got a valve that's much smoother, much slicker, less calcified than your traditional valve, that can sometimes present a problem, right? Where you don't have an adequate surface to kind of anchor the valve the way you need it to, right? So certainly that's one of the issues that we face with treating bicuspid valves.
What about tricuspid valves?
So tricuspid valves, like we talked about, are kind of the run-of-the-mill valve that you see with aortic stenosis, right? And so by the time a tricuspid valve has severe aortic stenosis, it almost certainly has a lot of calcium and it has a lot of thickening. You just don't see it otherwise, right? Because an otherwise normal tri-leaflet valve, by the time it becomes severely stenotic, has to have a lot of calcium and a lot of thickening. And so all the trials looked essentially at tri-leaflet aortic stenosis for TAVR because it works well, right? And so tri-leaflet aortic stenosis is very well treated with kind of TAVR technologies for those reasons. Part of a requirement for any program to be able to do TAVR is to have what's called a heart team, right? And so a heart team consists of this very broad range of people, right? That kind of all contribute to the same thing. So it includes interventional cardiologists like myself. It includes cardiothoracic surgeons. It includes a valve clinic coordinator. Our valve clinic coordinator, Lindsay, is here in the back. And so she runs kind of point on all our valve patients, right? So she follows them through the whole process. It includes cath lab staff, anesthesiologists, the cardiologists that are referring these patients, as well as imaging specialists. So all those people together kind of make up this heart team, right? Which was we were actually required to have it before you could start doing TAVRs. And so that was a requirement that CMS had before anyone could do these procedures. It's very important for some of the reasons that I've mentioned, right? TAVR patients tend to be older, they can be sicker, they can be frail, and so it's very important to kind of sometimes take a step back, right, and take a look at the whole picture, right, and try and understand if this is what the patient wants, if this is actually going to help them improve or achieve the goals that they're trying to achieve. And so that involves this kind of collaborative process, right, where the patient is identified, we see them in the clinic, and then we get some testing. But then that requires a lot of dialogue back and forth, right? Not just between us and the patient, but between us and the patient and the person who referred them in the first place to kind of make sure that we're all on the same page, right? That we're not just doing it because we can do it, but because we're doing it for the right reasons. And so that kind of collaboration tends to be very key when we're dealing with these kinds of patients. So this slide refers specifically to one particular technology, right? It's a valve that's made by Edwards Life Sciences. And so when we started our TAVR program in 2015, we started using the Edwards valve. And what this slide demonstrates is just kind of how different iterations of the valve over the years have improved to allow us to deliver better care, right? And so this is what the tube was initially that had to go into the body to deliver the valve. And as you can see, it's gotten significantly smaller. And the valve itself has gone through 3 iterations to where they've improved on the design of the valve in multiple different ways to try and make it better. So this is an animation of what the procedure itself looks like. Has anyone seen this on like YouTube or anywhere? Okay. So basically, this is how the procedure is done if it's done through the leg arteries, right, which is the preferred approach. It's called the transfemoral approach. And so as you can see, there's a wire that's placed up and over, right, through the leg artery, across the aortic valve and in the left bottom chamber of the heart. And then this catheter is then brought up over this wire. And this structure right here is the valve itself, right? So the beauty of the technology is that they've figured out how to crimp that valve down onto a catheter, making it small enough to then fit into an artery. So the entire, so the whole device is then passed up and over and across the aortic valve. So as you're probably starting to figure out, you don't actually remove your old valve, right? For the reasons that we mentioned, we need that thickening and calcification of the valve to hold it in place. The valve is inflated with a balloon, and then the balloon is deflated, and then that equipment is removed. And so what that balloon does is that it takes this crimped valve and it expands it, and essentially crushes the old valve out of the way, thereby anchoring it in place. They'll kind of flip it over and kind of show you what this looks like. So essentially there's 3 leaflets, just like, you know, the traditional tri-leaflet valve. But as soon as that balloon is inflated and then deflated, as soon as that balloon comes down, the leaflets start to work right away. And you essentially have a new aortic valve. The old one has been replaced. Questions about any of that? So this is an echo image of what that same process looks like. So what you're seeing here, you'll see it over again. You basically start seeing it kind of very narrow, and then right there you see a balloon expanding it, crushing the old valve out of the way. So this is just a different view of the same thing. But during procedures, when we used to do a lot of transesophageal echo, which is what this is, we would routinely monitor this process where we would watch it on echo as well as on x-ray. That's what that process looks like by echo. And once it's done, right, so this is a picture after the valve has been deployed. So as you can see here, these kind of bright streaks here are from the metal struts on the stent of the valve itself, right? And so you can see, I showed you the picture before of what aortic stenosis looks like, right? It's this very kind of thickened, calcified leaflets, but you can see here the new leaflets, right, are very thin and crisp, and they kind of come together very, very nicely. And so as soon as it's replaced, this is kind of, you know, just minutes after the new valve has gone in, it's already working. And this is just a different view of the same, where here you can see the leaflets, right, they open and close, they're these thin, crisp leaflets. Questions about any of that?
If you have a porcine valve, is the outcome about the same? Previous valve?
So you're asking if you were to put a TAVR valve inside a porcine valve?
Yes.
Yes. So so that's very routinely done, right? And that works quite well. It's actually a very, very simple procedure because you can essentially use the porcine valve or the old bioprosthetic valve as your marker for where the new valve needs to go. And so it basically just anchors itself inside the old bioprosthetic valve. And so we have these programs that tell us what size of valve we need to use, depending on what flavor of bioprosthetic valve you had put in, right? And so it figures out what the inside diameter is of the bioprosthetic valve, and then we're able to appropriately choose the right valve to go in. So this is an actual case that we did. This is one of our first few cases. So just to kind of orient you guys, this compared to the animation that we just saw, right? So this is the catheter that's coming up from below. This is the wire that's kind of passed up and out into the left lower chamber of the heart. Let's see if it starts up again here. And then this is the valve, right? We take a picture to make sure it's in the right spot, and then we slowly start to inflate the balloon. You can see the two ends of the balloon kind of inflating here, and then it's inflated all the way. And that takes that valve, which started out looking like this, right, completely compressed. The balloon then inflates it all the way. And then we deflate the balloon, and the valve begins to work immediately. So that was my big finish. So that was it. But that's how that works. We have a question.
Now, that valve is really neat. Is that for mitral regurgitation? Is that what you're fixing?
No. So this is for aortic stenosis.
Oh, okay. I don't know for sure what that is.
Well, what is aortic stenosis?
Yeah.
So aortic stenosis is this problem where the valve itself is kind of thickened and doesn't open very well.
But
So
with mitral regurgitation, you're also talking about these leaflets.
you're also talking about leaflets, but the problem is different, right? So in aortic stenosis, it's a tightness problem, right? The valve doesn't open well, right? In mitral regurgitation, it's a leakiness problem where it doesn't close very well, right? So instead of an opening problem with aortic stenosis, in mitral regurgitation you have kind of a closing problem where you have more leakiness of the blood back in the chamber. The other problem with mitral regurgitation is that it sits in a place that's very, very different from the aortic valve, right? So the aortic valve, let's see if we can. So the aortic valve sits in the aorta, right, which is essentially a tube, right? And so it's a somewhat convenient place to deploy this kind of a valve, right? The mitral valve, as you may have seen before, kind of sits in a very different structure, right? It sits in this kind of bigger, kind of oval space, which is a much more challenging area to try and deploy this kind of a valve. Right? Now that being said, for people that have a biprosthetic valve in the mitral position, right? For those people, we're able to put one of these valves in that mitral valve, right? But only because you've already got a valve there to begin with. Now there are minimally invasive technologies that are coming out, right, to fix mitral regurgitation. So those are still in the works. They're not exactly prime time yet, but stay tuned. Yeah. Good.
What are those three things in
These things? So I didn't do that.
Oh,
That wasn't me. But this person had open heart surgery before, which is part of the reason that they couldn't go back to get the valve replaced surgically, right? Because they didn't want to go back in a second time. But these are essentially sternal closure devices, right? So when they open the breastbone and they close it back again, some folks use these devices to kind of hold that bone together. But this made for a very spicy procedure because we couldn't see around it very easily. So we had to kind of finagle an angle that we could actually see the valve and see the work that we were doing.
How often do you see a valve rupture?
This valve?
No, just an aortic valve rupture. How often do you see that?
That happens uncommonly, fortunately, right? But it can be catastrophic if it does, right? Because if you think about, the real estate that you're talking about, all the blood that leaves the heart goes through the aortic valve and then through the aorta, right? And so if you have a rupture, which is kind of a frank opening of that area, or if you have a dissection, which is a tear in that area, that is a very, very, very bad location to have something like that.
The reason I asked that question, 50 years ago, I was called to the OB floor at Beta Clark. And because this young pregnant woman was getting very short of breath and turning blue. Well, I heard a funny murmur, and I didn't know what it was, so I called John Nolte. And John came over and made the diagnosis. And he called Hal Hardy up and said, saddle up. So that's 50 years ago, but I've never forgotten that.
Well, sure.
Yeah.
That leaves an impression.
Yeah.
Absolutely.
Yeah.
Is there a lot of work or any work being done on this
of the chronic hospital regurgitation situation?
There's not a lot of work being done. There are certainly some technologies, but they're probably not even as close as percutaneous mitral valve technologies are. But the move, right, is towards more minimally invasive treatment options. Right? So TAVR kind of set the standard for minimally invasive valve replacement. The mitral space is kind of following suit. But certainly there are technologies out there. They're just not prime time yet. But again, just like I said before, this landscape is changing, rapidly, right? And so what we know today probably won't be valid 10 years from now. That's certainly a process that's kind of very dynamic. Sure.
You replace the metal valve with procedure, make it. What are your only options?
Surgery.
Open surgery.
Yes, sir. So that's kind of the rub. So it kind of presents a dilemma now, right? Now that you have this technology, when folks present with the valve problem, somebody that may have gotten almost certainly a mechanical valve in years past are now getting bioprosthetic valves for this reason. Because it gives you the option to then put a minimally invasive TAVR valve into a bioprosthetic valve.
So they're replacing the mechanical valve with the rubber valve.
So somebody that would have almost certainly gotten a mechanical valve before, we're seeing that they're getting bioprosthetic valves now because it's taking this technology into account, right? It's taking your question into account, where down the line, if you have a problem with that mechanical valve, you really don't want to go through surgery again, right? And so those folks are getting bioprosthetic valves placed because they know that this is an option now. And so even if a bioprosthetic valve isn't as durable as a mechanical valve is, they're okay with that because you have TAVR as an option for when that bioprosthetic valve gives up.
So I don't have any option.
Well, I wouldn't say that. That's never true. But if you have a mechanical valve that has a problem, then this isn't an option to fix it.
The recovery time has got to get a lot better with this too.
Significantly, yeah. So if you're talking about open heart surgery, right, typically people are in the hospital for a little under a week, and then there's several weeks of rehab, and it's probably a few months before they're kind of back to anywhere close to baseline. These procedures, right, we do them typically on Mondays. Most people leave the hospital on Wednesday. And so if we do the procedure Monday morning, by Monday afternoon or evening, they're kind of sitting up in bed. They take a couple of steps around the room, in the ICU perhaps. They sit up in a chair. The next day, Tuesday, typically we'll have them go upstairs to a regular floor. A lot of times they walk. They walk themselves up the one flight of stairs to get to the third floor. And then the nurses get them walking around more. And then a lot of times they leave the hospital on Wednesday. So the recovery time is just, it's remarkable.
You talk a lot about that calcification of the valves and stuff, and I know you guys do the calcium scoring here.
Yeah.
If you do that in somebody younger and have a higher score, would this be something you'd want to watch a little closer?
So there is some data that looks at how much calcium is in a valve, right? So the coronary calcium score looks at the calcification in heart arteries, right? But you can use the same technology to look at how much calcium burden is in these valves, right? And so certainly we have some data, right, that says that if you have a very, very high calcium burden in a valve, that's something you may want to consider replacing. You can use it as, kind of an additional piece of information to all the other data that you use when you're trying to make those decisions. Good questions. Other questions?
Good job.
Oh, thank you.
Don't open it up, please, but you can see what a TAVR valve looks like. It's about $30,000, so.